Yes, I apologize. I couldn't be there in person, but sometimes these respiratory viruses kind of lay waste to your best made plans. So,
Well, we
so,
thank you for not infecting us, so thank you.
do you want me to start off?
Yes, please.
Okay. Thank you very much for the opportunity, Venki. Thanks again for this opportunity to present. So I've been doing GAEs now for about 4 years, probably done close to about 2,000 or so of these now. So we perform these only from the foot. I rarely perform these from the groin anymore. So I'm going to go over the first topic today, which is the genicular artery anatomy, and then variants and pitfalls. So as you know, this is kind of how the popliteal artery gives off the branches to the knee joint. Typically, the knee joint is supplied by 6 arteries. One comes off directly from the distal SFA at the level of the adductor canal slash P1 segment. And then there's one that comes off the anterior tibial artery called the anterior tibial recurrent genicular artery. Our focus, though, will be on these 5 arteries, the DGA, the 2 superiors, and then the 2 inferior genicular arteries. So this is a must read. I don't think anybody should be doing genicular artery embolization in this day and age without having read this paper thoroughly and then having hopefully reread it. This was seminal work performed by Dr. Mark Little and his colleagues from England, where they did autopsy specimens on people who died with osteoarthritis. So there are many, many variations in the takeoff and the course of these arteries. And it's very important to understand these, just not to be able to cannulate them, but also to make sure that you don't have the most dreaded complication that's seen in these procedures when they're performed poorly, which is non-target embolization. So we'll get one artery out of the way first. This is the middle genicular artery. You can see a little MGA here. This is the artery that actually supplies the cruciate ligaments. You do not want to embolize this artery. If you do, you'll take somebody from chronic pain to an unstable knee joint where the ligaments can just get shredded. So in addition to that, there are a lot of these anastomoses that we need to talk about. So I'll jump right into that. So first, the medial anastomoses. So the first anastomosis that you need to be aware of on the medial aspect of the knee joint is the most common one, and it happens in about 80 to 85% of patients. This is what I have kind of noticed too, which is the connection between the DGA and the superior medial genicular artery. So typically, when you place your catheter in the DGA above the connection with the superior medial, and you inject, you'll see stuff go retrograde into the superior medial and then down the popliteal artery. So it's easy to kind of get rid of this problem by advancing your catheter a little further down past anastomosis and then injecting slowly. The second one that you need to be aware of is between an unnamed branch and the superior medial genicular artery. So this also refluxes back into the popliteal artery. So the fix for this is to make sure, again, you advance your catheter in deep enough that you don't easily reflux back into this unnamed branch. There are, I think, a total of 5 or 6, but this is the third most common between the DGA and an unnamed branch, again, that refluxes back into the popliteal. So you want to make sure you get your catheter all the way down here, way past these anastomotic points. This fourth one is something that Dr. Little's paper describes this as 5%, but I gotta say, I mean, now I've done thousands of these cases and hundreds of these cases, sorry, and this is a lot more common than 5%, I think. One of the big sural arteries and the inferior medial kind of coming off of one common trunk. This is a common way, pathway for embolic particles to go down the sural arteries into the calf muscles and into the sural nerves, causing paresthesias. Sometimes I have, and this happened a couple of times during my early cases, where I would inject permanent particles and they would actually form painful calf nodules. So obviously that was more than 1,000 cases ago, but I've learned my lesson. So, so you have to be very careful about this sural artery. On the lateral side, between the inferior lateral genicular artery, there can be a connection to the sural branch again. This is very, very, very important to understand. And if you don't pick this up, you have a real chance of actually embolizing down into the artery that supplies branches to the deep perineal nerve here, and that can be a devastating side effect, as a devastating complication. So we'll talk about that. And then one more is an unnamed branch in the superior lateral genicular artery. Typically, you get a lot of skin embo with the superior lateral genicular artery, but sometimes you can have this branch that goes back into the popliteal and refluxes back down into the posterior tibial and things like that. So very important to understand that these arteries, while on an AP view look like they are nice and easy, they're not. They actually are coming at you, and they're not coming at you in a perfect sort of 180 degree plane. They're kind of coming at you at an angle like this. So the typical rule is, if you want to get the medial arteries, you go contralateral obliques onto the lateral side, and if you're going to get the lateral arteries, you go the medial side. And then depending upon how many arteries come off near the origin of the artery you want to engage, you might need to do a little cranial and caudal. So when you have an IL, an inferior lateral like this that comes off from P3, that's a nice case. You can easily get into that. Your catheter usually just pops in from the foot. But when you have an inferior medial like this that comes off amidst a bunch of sural branches, and there's a double density here, it can often be a little challenging. So you can see here there's 24 degrees of RAO, but we had to go quite a bit, almost about 50 degrees of RAO before my catheter popped in to get into the inferior medial. So what about this one? So take a look at this. So this is what we call the scout shot. We take an initial sort of lay of the land. And where in the world is now the inferior lateral coming off of? Is it coming off of this common branch? Is it coming off of this double density? Is it coming off of this sural branch and then going this way? So these things can be a little challenging. So in those kind of situations, the first thing you do is actually not enter that artery. Take the low-hanging fruit out of the picture. So we got into the DGA. And now I thought, okay, I think this is coming off the sural branch, and you can see my catheter, my wires down the catheter. And then I inject. Look at this. I'm completely in a different branch, some sural branch, right? Completely in a different branch. So this can be difficult. So what did I do again? Extreme oblique. You can see actually the edge of the table is now coming into the view. So once I was able to notice that this was a down pointing inferior lateral, I was able to get my wire and my catheter. But look at this now. So going back, this is 39 and 16. Now look at a near AP view. That catheter is actually pointing at you. It's coming at you in a near AP view. So these are important things to understand while cannulating these arteries. If you don't understand these, number one, you won't be able to get into them. Number two, you'll cause all sorts of complications, right? So skin complications are the most common. Usually, if you put an ice pack on there, they're not too bad. With imipenem cilastatin, it's not really permanent. With the permanent embolic particles, you can get pretty bad skin reactions, sometimes ulcers and things like that. Treatment is conservative. Number two, depending upon how much embolic volume you've used, usually people get a little post-embolization synovitis. And we typically negate that by giving them a Medrol, 4 milligram Medrol dose pack. That usually helps, and I tell them to ice the knee too. Now, this is one case that Venki sent to me and said, man, what the hell do I do about this? I got called from the ER. There's not a whole lot you can do, unfortunately. So this is what happens when you don't know what you're doing and you inject volumes or volumes of embolic particles that are too high, or you cause a lot of non-target embolization. So this is the treatment here is just conservative and supportive. Similarly, it can happen around the shoulder. This is a patient that went to Duke. He was a longstanding PAD patient of mine, went to Duke to get his shoulder embolized, and unfortunately this happened. He was also immunocompromised, so that may have had a role to play. The other complication you got to think of if you that when you do GAEs is that you should never ever cause bone necrosis. There are at least now 3 studies, MRI studies, that have shown that there should be close to 0 chance of any bone necrosis. If you do, again, poor technique usually. This is something that the IR guys try to scare you when you try to start doing these GAE procedures, saying, "Oh my God, you're going to cause distal embolization and all that." I mean, you should really never get gangrene. Gangrene is ridiculous. I mean, you did something really wrong. But you can get ischemic ulcers and ischemic blisters. Again, treatment's usually conservative. You almost should never inject an amount of embolic that cuts off the arteries. This is the worst complication in my mind that you can get if you are untrained or if you don't know what the hell you're doing. So if you damage the peroneal nerve, the foot drop that you get is irreversible. You cannot do anything. I was asked by one of my lawyer friends to kind of help support one of his clients, and I said, "You just need to settle. There's no way you can try to prove that this wasn't the operator." So unfortunately, this can happen too if you don't know what you're doing. So you got to be aware of this. So I think that's all I have time for. I'm sorry I may have gone a little over.
Yeah, thank you very much. And I think